Interventions for vestibular rehab. Introduction. Vertigo is defined as the illusion of movement. Patients may describe that they sense their environment is moving or that they see the environment moving or spinning. It is most commonly seen in acute stage of unilateral vestibular hypofunction, benign paroxysmal positional vertigo, unilateral brainstem lesion. Common balance tests and expected results related to specific diagnosis. Gold standard method for diagnosis of BPPV, which is described later in the video.
The Hallpike Dix test. The patient sits on the examination table and the clinician turns the head horizontally 45 degrees. As the examiner maintains the 45-degree rotation, the patient is quickly brought to supine position with neck extended 30 degrees beyond the horizontal. The examiner must look for nystagmus and ask the patient if vertigo is being experienced. The patient is then slowly brought back to the starting position and the other side is tested. The side that reproduces the nystagmus and vertigo is the side that has BPPV.
Interventions for BPPV. General goals. The otoconia will be returned into the vestibule. The patient will demonstrate reduced vertigo associated with head motion. The patient will demonstrate improved balance. Patient will demonstrate independence in daily activities involving head motion. Canalith repositioning maneuver, Liberatory also called as cement maneuver, Brandt-Daroff exercise.
Canalith repositioning treatment for right horizontal semicircular canal BPPV. Initially, the patient's head should be placed in 20-degree cervical flexion. For treating a right-sided horizontal canal BPPV, the patient's head is initially placed 90 degrees to the right. Next, the head is rotated 90 degrees to the left. The therapist should wait in this position for 15 seconds or until the vertigo and nystagmus stops. The head should then be rotated another 90 degrees to the left. Again, the therapist must wait for 15 seconds or until the vertigo and nystagmus stops. The patient must then roll into prone position and await the signs or symptoms to stop. The therapist must attempt to keep the head in 20-degree flexion during the transition from sideline to prone. Canalith repositioning maneuver for posterior or anterior semicircular canal BPPV. The patient's head is first rotated 45 degrees towards the involved side. The patient is then moved into the Dix-Hallpike position with the affected left ear towards the ground. Next, the head is rotated 90 degrees to the right. It is important to maintain 30-degree neck extension during this step. The head should now be positioned 45 degrees to the right. The patient is rolled onto the right shoulder. Slowly brought up to the sitting position, head still rotated 45 degrees to the right. The patient may then be fitted with soft collar.
Liberatory maneuver, also called cement maneuver for right posterior semicircular canal BPPV. The head is rotated to 45 to the left side. With assistance, the patient is then moved from sitting to right sideline and stays in this position for 1 minute. The patient is then rapidly moved to 180 degrees from right sideline to left sideline. The head should be in original starting position, left rotated, nose down in final position. Brandt-Daroff treatment for posterior semicircular canal BPPV. The patient starts in a sitting position and turns the head 45 degrees to the left, then quickly lies down on the right shoulder. Patient should be instructed to remain in this position for 30 seconds or until the vertigo stops. The patient then slowly returns to the starting position, maintaining the head rotation until the sitting upright. Next, the patient turns the head to the opposite direction to the right and lies down on the left shoulder, observing the similar 30 seconds time guidance.
Interventions for unilateral and bilateral vestibular hypofunction. Goals: improved stability of gaze during head movement, diminished sensitivity to motion, improved static and dynamic postural stability. Interventions: gaze stability exercise, postural stability exercise, motion sensitivity, which is called habituation training. Reference Sullivan.